Dipak, hi, and thank you so much for joining me here on Faces of Digital Health to discuss where Europe is at the moment when it comes to healthcare data interoperability, making the most out of healthcare data, and how to leverage the potential in the future. You're the president of the European Institute for Innovation Through Health Data, a thought leader. Anyone that's in the health data space in Europe is going to mention when it comes to interoperability and understanding data standards. So with the first question, let's reflect a little bit on the work that you've been doing and the progress you see that we've made in data in healthcare in Europe. So how would you describe the last, say, 10, 20 years? What stands out to you? Is interoperability still a word that brings out a lot of frustration in people? Have we made any progress? What comes to mind when you start thinking about the past and the present?
Well, that's a really great opening question, a complicated one in a way. So let me give you two examples of how that question might be answered. If you were looking at the efforts of some of the major international standards bodies who are extremely active in Europe, or you were looking at some of the large electronic health record system vendors, or you were looking at a regional or a national health system, they would say interoperability is a major driving force around new procurements and upgrade procurements to electronic health record systems. People recognize that there is no longer an acceptance that each individual healthcare organization is a data silo, that for patients to experience joined up care, safe care, the systems have to talk to each other. And for us to reuse data, this is now a really important thing because single individual hospital or GP data is insufficient for learning, for research, for decision making, and so on. But then, if you were to speak to patients and say, what is your real life experience? When you go to a hospital from your GP, is the information in your GP computer system available to your hospital specialist? When you've seen a specialist and you need to go to the GP, does the GP have in a nice electronic form your information? Can either side produce a consolidated medication list on screen? Can either side do a chart of your lab results where some of the tests have been done in a hospital, some in a GP? What's your real experience? How often do you have to repeat your medical history when you go to a new place? I think you will find largely across Europe today still a relatively disappointing answer from the on-the-ground people. So I think the reality is what we have out there is hybrid. It's a mixture. So there are centers of excellence in the adoption of digital technologies, electronic health records, connected systems, which are able to have high quality computerized records with a lot of structured and coded data and some ability to exchange data locally with GPs or other hospitals. And you have other areas, usually it's not a whole country, it may be a region within a country where you're still looking at a rather older generation environment where paper and electronic systems coexist. So some of the information's on paper, some of the information's on a computer. When it's on a computer, it's in free text letters and reports. It's not in structured and coded searchable data. But having the data in a computable form is important for communication purposes. So if a patient needs to be seen in an unexpected environment, data can flow to that location and the clinician seeing a brand new patient can have some background. But also there are a lot of digital health tools that use computable data in the electronic health record to help make care more efficient, more safe. Clinical workflow systems, clinical guideline systems, reminder systems, safety checking systems, drug-drug interaction checking, drug-allergy interaction checking, problem list management, and so on.
Mm,
So there's a lot of workflow systems, a lot of non-AI algorithms, old algorithms that are still not being used well because the underlying data isn't good enough for these
mm,
algorithms to work properly. And so we have tools that could help clinicians be safer, be more effective and more evidence-based, to cooperate better as multi-professional teams, which are not being used to their maximum extent. So yes, on the good side, the momentum is powerful. The commitment of many, many decision makers, including budget holding decision makers, is strong. Let's not knock them. But we have a massive legacy and it's improving rather slowly. And I'm sorry to say, still most patients are not getting the maximum benefit we could from the technologies that are already here. And
yeah.
that leaves us in a compromised position as health systems to benefit from what the next generation can bring us, such as artificial intelligence.
Mm, I
Artificial intelligence can be designed on data sets, but it eventually has to run on the records of real patients. And if those
absolutely.
records are incomplete, the AI can't run, or it will run unsafely, inaccurately. So I
There,
think
there's
we have still a lot of work to do.
there's another factor, when it comes to AI. In the last probably decade, there's been a lot of discussion that you need to separate data from your applications. And I think with the development of AI, that need is becoming even more apparent, because if you want to develop AI systems that need to uh, draw data from different systems instead of one platform, then that system becomes very slow, very energy consuming, and harder to design. So from that perspective, what do you see we've done in terms of data governance, in essence, because connectivity, yes, has happened. There's national portals, patient portals, where you can see your data from different healthcare providers. But the other question is, to which extent is that based on thousands of connections instead of, a platform approach?
Well, again, you're asking really interesting questions, I can't deny. So let's quickly start with the first bit of your question about separating applications from data. You're absolutely spot on that if we go back 10 or 20 years, as hospitals grew and expanded their electronic environments, they would add new applications. So starting with laboratory systems, pharmacy systems, clinic management, appointment scheduling systems, then through to specialized systems like endoscopy suites, radiology systems, I should have mentioned, but also things like intensive care unit systems. And very often these systems would become more and more sophisticated, more and more clever, because the data was held internally within those subsystems by the manufacturer of the system, who could rely on the data that they themselves were responsible for. But this created a fragmented environment. A lot of hospitals, when I was looking, say, a decade ago, would report between 20 and 30 separate subsystems, each of which would have its own data. And that led to a mess, frankly, in the data. So there's been a real push to say, even if some of those systems still need a local copy because they do reasoning and other things locally, they should always write a copy of the data into a central electronic health record so it can be accessed and reused by other systems and, of course, shared with other actors. I referred earlier to hospitals, GPs, providers, but you've introduced the concept of the patient, and I think that's a really important actor for us to be mindful of. Patients do benefit from seeing their data. But I would like to call out a little bit that a number of health systems have introduced patient portals where a patient can view their record information, just look at it. And for a small number of patients, that has proved to be quite helpful because they can look at their recent lab results and so on if they've had a test. But in general, most people find the majority of the content of their record rather boring to look at. They know what it says. They know. And if they look uh, once the system is live, they look once. Why would they look a second time after 6 months? They might look for a recent lab result, but they won't look at the rest of it again because they know it.
The date of the next doctor's visit is there. That's why I go to the PDFs
That's
of my
useful. No,
discharge
no, that's
letters.
great. So
Yeah,
that's good.
yeah,
So
yeah.
it's the immediate short-term value is great, but the long-term value is nearly nothing because most of those portals, when they were developed in the first place, were passive read-only. And I think that really is quite limiting. Now, what we see with the European Health Data Space regulation is introducing something rather new and I feel exciting. Not for the whole EHR, but for a subset of data, a core data set, which is called the European Electronic Health Record Exchange format. A patient will be able to download a complete copy of that data in a computable form. And what that does is for the first time, in a standardized form that will be the same standard all over Europe. What does that do? It absolutely opens up the market for developers of applications and smart tools to give patients added value on top of the data, giving them views, giving them trends, giving them charts. We're involved in projects that might allow a patient to capture additional data themselves, for example, their health outcomes, and they could maybe do a chart of their experience. I'm going to pick as an example pain. They could do a pain chart over the last 12 months, pain scores they've collected against the intensity and type of pain treatments or disease treatments they're getting. And they could on a timeline say, when the doctor changed this dose, I can see my pain levels went down. Patients will be able to do that. We've got projects where patients would be able to cross-match automatically their key patient summary facts with information about the medicines they're taking, so that only the information that's most relevant to that type of patient gets highlighted. Because patients get overwhelmed with far too much safety and administrative information. I don't, for example, need to read the pregnancy-related precautions in the drugs that I take. And a smart app would know that and just put them on the back and say, if you're interested, they're still here. We're not removing them. But actually, you want to see things that relate to your high cholesterol, for example, because we know you have that from your summary. I'm seeing now a real possibility for smartness on top of that. And I think that's going to give patients a really fantastic opportunity to become more active in the way they manage their health, contribute to their own disease management, and also prevention and wellness. They'll be better informed and tool supported. Very
To
exciting opportunities.
it's there's I have two comments or
Mm,
maybe expectations of what's going to happen there. One is that probably if you are as a patient able to download your whole medical history in a computable format, then OpenAI, Anthropic, and other LLM providers that provide chatbots to consumers are going to know about a lot about European healthcare very soon. That's one, and we know that OpenAI is also already working in healthcare. And then the second is, how is the dynamic between clinicians and patients going to change? Earlier, when you mentioned that despite the fact that a lot of things are digitized, patients still need to repeat the information to clinicians, their medical history. That's probably because doctors don't really have time to prepare a day in advance for all the patients that are going to come to
of
their
course.
office. So
Yeah.
it's an interesting thinking of the dynamics that are going to
Mm.
change. Are you in any way concerned about, actors such as OpenAI or companies outside of Europe that provide these solutions for AI? are going to get all the information about patients, because when you want a medical answer, you don't care as much about privacy necessarily. Then we'll go to the changes in the dynamics next.
Yeah, again, you ask such rich questions. I'm delighted with your questions, but they are challenging to answer. I think that I would not necessarily single out the famous names in AI only. I think that people, when they have a copy of their data in a standardized computable form, and they are able to forward that record to anybody else, they can do so in a guided and well-governed way, or they can be misled to reveal information. I mean, it's no different to people posting personal data on social media platforms, and it's no different to people accidentally being tricked into giving their bank details to a scammer. You know, when people have information, they are vulnerable, and we have to accept that. So one thing we have to do is to invest a lot more in education of the public. We need people, and not just, I mean, school children are important, the next generation, but a lot of people who are out of school, including you and me, are not going to be in school learning these things. So we have to learn in another way. And we need there to be widespread education to the public about how to look after their health data safely, so they release it only in trustworthy channels. I would love to see an accreditation process, certification process, and say that if you are being invited to give your data to somebody who's helping you to answer a question or whatever, that actually they have a certificate that they can show that they have been through some governance process, which means that they are protecting they are applying data protection to your data. They've got rules about the purposes for which they're using the data. I mean, the GDPR is very clear on this. If you're sharing your personal data, and of course, your personal downloaded health record summary is your personal data, it's absolutely GDPR data, then the purpose of processing has to be a legal basis, and you have to declare that. And as a processor of data, a new controller receiving data, you can't start using it for other things. So if you have an agreement with the patient that they can share a little bit of their record in order to get a very useful answer to a preventive health question, or can I buy this over the counter if I'm taking these meds? And it says, well, upload your summary and I'll tell you if you can buy this, if you should take this medicine over the counter or not. But I'm only going to use your data to answer this question. Will I keep it forever? Will I delete it after I've kept it? What will I do? If there is honesty and transparency about that, the patients, consumers, the citizens might be safer. But I do worry about that, I agree. The difficulty is if we're over-prescriptive, we will also dampen the market of possible inventions that could deliver a huge amount of patient value.
Yeah.
And I think education, maybe certification and accreditation type methods need to be pushed to their limits, really, to help everybody get the best and be safest with the data.
Mm-hmm. I guess the questions on my end, just you basically are giving them to me on an open platter, because I was just about to ask what you think about the stifling of innovation when we try to be too prescriptive. From the patient perspective, I always feel very safe in Europe because of all the regulation that we have. And I know that, looking at the American market, for example, I know that they work fast, so we don't have to go through the mistakes that they're making, especially with AI, for example. But I remember a few years ago, we were together at the European Patient Forum Congress, and you had a wonderful workshop, and the topic was data, I think data ownership or giving consent for research, because we
Yes, I
often
remember
say,
that. Yes.
yeah, and what really stood out to me there was, because we often hear, like, patients want to have control of their data. I want to know how my data is used. The biggest issue also for clinical trials is that patients never get feedback information on Was their data helpful? Was it not? It's just kind of disappears into the void. But you made a really good point, which was, can you imagine that for every clinical study you would get a notification? Do you allow your data to be used for this research, with 10 pages of what that research is? And if you got like 5 of those requests a week, would you really take
A
the
day,
time to
a
read?
day, not a
Yeah.
week. No, you won't. You won't. And I don't think that's realistic. It sounds very easy to say, let the patient decide, but it's also a way of dismissing the problem. It's a complicated problem and it needs a sophisticated approach. So I think that if we're looking at now, if we put away my previous answer, which was about improper uses of the data, but we still look at proper uses of the data, but still where the patient should have a choice about whether they would like to or not have their data used. I think we are in an area that is complicated, but is got to be addressed, and it's got to be addressed urgently, because the European Health Data Space Regulation offers patients the opportunity to opt out of their data being reused in what's called secondary use, which means for research, for public health, for health service strategy planning, etc. So they can opt out of that, and each member state will have a way of communicating to patients what their choices are, and then they will have to have a way in which patients can in some way indicate their choices if they wish to opt out of something. The difficulty we have is what actually will be the choices. How will they be described? What level of detail will the choices be? Will you have choices to say, I'm happy for my data to be used for research, yes or no? Or will it be, I'm happy for my data to be used for drug development and safety monitoring, but not AI development? Will it be like function, if you like? Or will it be, I'm happy for my data to be used by universities and academic bodies and not-for-profits, but not industry, for example? Or will it just be industry as a single word? Or will it be, I'm happy for my data to be used by the pharmaceutical sector, which develops drugs and vaccines and gave us COVID vaccines. I'm not happy for it to be used by big tech, etc. We have no idea what the way in which choices will be. When
So
I've
that
spoken,
hasn't been decided yet then.
well, it's not only that it's not decided, each member state is free to decide separately. So we could have 27 different ways in which those choices are framed, 27 different granularities. And that could leave us with a little bit of a mess in terms of, if you're doing multi-country studies, you might be allowed to get data from Germany and France, but not from Spain, for example, just because you're not permitted in the opt-out sense. So I mean, you get some data from patients who didn't opt out, but everybody who opted out might have opted out against you having the data in one country, but not in another country. So that's a mess. I think it's going to make a public education mess, because people will see different instructions, different education, the promotional messages, the explanatory messages. Yes, country-specific messages can be country-specific, but there's a lot of things that are developed that are educational that are not country level, which will be confusing because they'll be true in some country, not in others. But the biggest risk we have with opt-out, with patient choice, is introducing bias. We've talked about AI a little bit before. A big challenge with AI development is having data sets that do not contain too much bias. Let's not pretend zero bias can exist. It's impossible to be perfect, but you want the data to be as representative as possible of the population who might use your algorithm. But if a subset of the population opt out to a greater extent than another subset of the population, people might be vulnerable to fake news and misinformation and scaremongering. So they might opt out asymmetrically. A particular ethnic group might be targeted for fear-mongering campaigns to say, you better opt out. They're going to use your data to discriminate against you and so on. I mean, you know that the fake environment is very clever in the ways it invents misinformation. we'll end up, the risk that the bias that is in today's data becomes more severe. We get more extreme, amplified bias, and the algorithms will be less applicable to the populations. That's one of my concerns.
Mm-hmm.
And the counter argument to that, the way that we try to tackle that has got to be, firstly, again, public education. Why does data get used for research? Why is it needed? How is it used? What good comes when your data gets used? But also, what rules do these organizations have to play? When I work with some of the companies that do research on data, I'm actually very impressed almost always with what I find, that they have very strong rules about internal segregation. The data doesn't get given to a company, it gets given to a team within a company who hold it close to that small group of people who are performing a particular investigation. It's held with a lot of information security, a lot of rules, audit trails, strict sanctions if anybody does anything wrong. And I think if the public really were exposed to the detailed care that's taken about their data, they'd be more reassured.
Mm-hmm.
But I haven't seen on the television any
Yeah.
programs about this topic. I don't see these things being featured. And I think that
Yeah.
organizations like my own have got to actually do more to help to explain to the public, not to try and persuade them or dissuade them. That's not our role. We have to be neutral, but education with facts,
Mm-hmm.
education about the methods and the approaches that are largely adopted so that the people can make an informed decision. Today, my worry is they're not going to make an informed decision. They'll make a decision based on fragments of information and influenced, unfortunately, mostly by scare stories, not by good news stories.
That's a potential pessimistic or dystopian scenario. What's the
Well, unless
optimistic
we all
one?
work together against that. I mean, I don't think this is a fait accompli, that
Yeah.
the disaster is coming, but I want to highlight the risk because
Mm-hmm.
I think that what is needed is for all of the stakeholders in the healthcare and the research space to collaborate around, firstly, defining good practices, saying these are the minimum standards we all sign up to, that people will be signatories of a code of conduct, a code of practice, and say, we are all, we have this badge on our website. That means that if we get any data from you, this is what we do with it. This is how we protect it. These are the limited reasons we will have your data. Yes, drug development, yes, vaccine development, yes, digital health technology development, yes, disease understanding, yes, risk profiling, marketing, no, health professional influence, no, insurance premium manipulation, no. What we need is for places that will actually make it very clear to the public how their data gets used, and then how do we protect your data? What do we do? What are the rules we follow internally? And
Mm-hmm.
these things can be expressed in lay terms. I helped with colleagues to write material that is on the website of Data Saves Lives. So that the word data saves lives without any spaces in between the words, .eu. Datasaveslives.eu is a website that is the portal to a campaign that is run by the European Patients Forum, which is helping the public and helping patient organizations to better understand some of these things.
Mm-hmm.
We've
And
been
take away the
we've been
fears.
founding supporters of that. Our institute is a founder of that, and we are delighted to still be strongly connected with that activity. It has a limited budget. It cannot be Europe's only solution to the problem. Our own institute also, we'd like to get more money so we can work on public education resources. And I think there are plenty of others around Europe who could contribute. But also, we need the organizations that have data, that collect data, that engage with patients to be able to inform patients about uses of their data that patients should be pleased about happening. I mean, who doesn't want, if they get cancer in the future, that by
To
looking
have
at
the solution for
looking
this.
at their
Yeah.
genes, you can say, for your genetic type, this is going to be the most effective cancer drug, not the one that many other people get. This is your choice of drug. I mean, who would
And
not
now
want
you're
that?
now you're entering into kind of the optimistic or
Yeah.
potential of EHDS that we do want to see. So let's talk a little bit about that. So
Yes.
the EHDS legislation has been put in place. What progress do you see has been made in the last year now that the details, the technical details, need to be defined? And also, if we let our imagination a little bit loose on the optimistic side, what do you think the best case scenario of EAGDS could be in the next 10 years, knowing that despite the opt-out risk that you mentioned and all the challenges related to that, we do know that, based on the design of national patient portals, when you do an opt-out model, there's usually not
Yeah.
that big of a churn of patients that would say, hey, I do not want my data to be added. It's usually the other way around. If you want to do the opt-in model, then you don't get patients. If you do the opt-out, most people don't care. So what's the optimism? Where do you see the potential benefits? And more importantly, the fragmentation that you mentioned earlier in terms of every country again having their own rules. What are the chances that Europe would get unified on that front a bit more than the worst case scenario?
Yeah. Okay. Again, a great, rich question. So let me divide my answer into three parts. In terms of preparing to be EHDS ready, we had a conference, our institute held its annual conference 2 weeks ago, where the EHDS was a huge topic. We had lots of streams looking at different facets of the EHDS readiness challenge, health data holders getting themselves ready to use data catalogs to describe their data sets, health data access bodies starting to be formed, or if not yet legally formed, prototypic bodies starting to take shape, working out how they will run, what will be their rules of engagement, and so on, educating and capacity building in the workforce. So I was actually really impressed with the way in which across the stakeholder communities, people are really getting ready to engage with the EHDS, not to engage with it theoretically, but to deliver it in practice. And I think that's tremendous. I think, though, the discussion point we started this session with, which is about the present day legacy of our health data in inconsistent hybrid paper electronic systems, free text and structure and codes being a mixture of national codes and international codes, and interoperability interfaces not yet being that robust and well widely developed. I think being able to deliver on the exchange format data on every European citizen, consolidated across all of their healthcare organizations inside a country, so you have one really good summary for the patient that is then capable of being used for care or for research as well. I think there's quite a few years of investment needed. So we can get ready and be excited by the preparedness of people and organizations. But preparedness of the data, I'm afraid we're a bit behind. And that's because the data has never been really strongly valued as a resource. So we've underinvested in health data for a couple of decades at least, maybe since computers started in healthcare. We've underestimated the value of data. We've underestimated what we need to do to have good data. And so I think we've got a big catch up to do. What it means, I think, is the EHDS will be operational, probably on schedule, but with less data than we initially hoped. And the data volumes, the data richness, the categories of data will need to grow a bit more slowly. But again, here is where we can work together. There is a potential to accelerate data readiness as opposed to organizational readiness and actor readiness. The data readiness can be accelerated if we decide it's a multi-country priority and we work together, help each other, share good practices, share things like data quality assessment methods and tools, and really help to look at improvement strategies. We have to be careful, though, because the risk with data quality is all of the people who want to reuse data would like data of beautiful quality, clean, intact, complete, structured, coded, consistent, and all those nice things. The people who create the data are an overworked workforce at the front line of delivering patient care in a post-COVID environment where most national health systems are still catching up on the backlog of postponed care, where we have a workforce criticality in most health systems. So to say the solution to EHDS data readiness is to beat all of our health professionals with a stick and tell them to do better with data entry would be a totally unforgivable approach. We have to work with their limited capacities because of the workload and the workforce shortages. They need smarter systems, they need better tools, and they actually need computable data to work for them. The algorithms I mentioned, the workflow support, the reminders, the prompts, the care pathways, a lot of the things that clinicians spend time on today at the computer would be capable of either full automation or semi-automation if their systems were smarter. And I really think we have to help the clinical coalface. Sorry, that's an English expression, but I hope your readers and viewers will know what I mean. The clinical coalface workers need to be helped to enter data that delivers better value to them and to everybody else. And I think that's an investment we are still well behind making.
Mm-hmm. I often wonder, especially at this point, to which extent the everybody involved in EHDS, especially the IT vendors, are relying on deadline extensions. So, there's
Yeah.
kind of timeline that EHDS has and goals that we want to achieve, but it's not uncommon that these get delayed. So from that perspective, what do you think are going to be the key discussion topics in 2026 or 2027 when it comes to EHDS? And what do you think about the delays which are kind of expected?
Well, I think that postponements and delays can occur for two reasons. One is everybody's working as hard as they can, but they underestimated how long it would take. And the other one is people are reluctant to start, and a delay gives them a breathing space to not act yet, or to say, I'll wait for others to act and then I'll follow. The first, a genuine finding that things are taking a bit longer when it's clear everybody's working at maximum speed, is forgivable in my view. But just treating an extension as a breathing space, a chance to take it easy and not act yet, to me is not forgivable. Why is it not forgivable? Because whilst we are not making the maximum use of data to support safe care to individuals and to learn from the data, we are in the meantime providing healthcare that is not delivering the best it can to patients. What does that mean? Inevitably, it must mean that there are patients getting care which is not the best it could be for them. They're experiencing complications or delays. They're receiving treatments that may not be the best that science could bring them, that we can invent, not things we can't invent. There are things we could invent if we had the data. So really, we are harming patients as we relax and take it easy and are complacent. And I feel, perhaps it's with my age now, I'm too frustrated with that. I don't find that easy to accept. I really think now we should see health data readiness for safe continuity of care and for learning is an emergency. And it really needs everybody to work fast and furiously together, not individually in silos, but collaboratively now, to really work together. Public and private must work together. I've experienced a lot of public-private partnership projects. I'm delighted to have been part of Innovative Medicines Initiative and Innovative Health Initiative projects. and also a number of smaller projects where we've just worked more informally in collaboration. Public-private in a pre-competitive space works almost always extremely well, brings out the best of people, brings out the best of organizations, and the end result capability to conduct the innovation or the research is so much richer. I'm really, and I think we now need to just throw aside prejudices about this and really work together.
Mm-hmm. There's one thing that I wonder. So we mentioned earlier that to a degree, doctors don't have time to just have a detailed overview of every patient that they see, so they just ask patients, tell me about your medical history or key things.
Mm-hmm.
And at the same time, patients know all the details about their medical history, and when faced with a particular medical challenge, today they can use even PDFs, even data that's just read-only text form with AI to come to new ideas, to put in a lot of effort and time that doctors do not have just to get to new answers. So that's a huge contrast where you kind of get actionable insights with tools that are in no way regulated as medical tools are. So my question here is, to which extent do you think we're going to have these two parallel worlds where on the one hand you have a subset of, say, chronic patients that can really take good care of their health because they're proactive, because they do deep dives, they work together with their clinicians. Clinicians are open to taking on the knowledge that patients find out, versus the world where this would be all done by clinicians and enabled with the tools that are developed, checked, validated, certified, MDR compliant, AI regulation compliant. It's like, it's a difference between what you can use already today as a patient versus something that doctors are going to be able to use in 5 to 10 years time, because that's how long it's going to take to develop a product that's going to fit under all the regulations. Yes. So how do you see the changing dynamics from this perspective?
I don't think you can resist asking me interesting questions. This is a really wonderful question. So thank you for that. So firstly, to take a small part of your question, clinicians and information overload. The more we collect on patients, the more that they have multiple chronic diseases, because that is what's happening now. The first disease doesn't kill us, but thanks to healthcare. So we survive the first disease, we get the second disease, the third disease, the fourth disease, we're living longer as well. So our records are getting more full of information. And there is a risk of information overload. You say, how can a busy clinician quickly, before the patient comes into their clinic or in the emergency department, quickly digest a large amount of information? And I think that we have got to leverage the smartness of tools, including in the future AI, but even not yet AI, just queries, analytics, layouts, clinician dashboards, disease dashboards. A lot more work is needed. If we recognize the risk of information overload, which is not just a workload issue, it's a safety issue because you might miss an important fact because you don't spot it, is we need much more investment in ways of rapid assimilation of just-in-time information needed for a particular care scenario in complex health record situations. That's without doubt. And I think we're not leveraging enough the use of voice, the use of sound, the use of graphics to help clinicians to get quick overviews. So that's one thing. I think then I want to turn to the patient. And I now want to go back in time. When I was a GP many, many years ago, the internet arrived as a resource for patients to look things up online. Where before they had to go to a library, they could now do it in the comfort of their home, and they could search successfully. And it was well known in those early general practice days of mine, patients coming into the consulting room with 10 or 20, 30 pages of printed internet information. Doctor, I've been taking a look at this treatment you've got me on. I've been looking at this disease, and I think there is some other ways I could be treated, a different drug, or there's some concerns about this drug. Look, why don't you take a look at this? And the protests from professionals about how can we find time to read a 30-page internet printout where we really have no quality assurance on which sites were looked at by the patient. They could have been taken to all sorts of sales and marketing type pages where people were trying to discredit a treatment so they could sell you another one instead. This was unreasonable. Now, I don't think your question today, honestly, is very different to that. It's about what do we do with patients that actually do make the effort to upskill their knowledge about their disease, about their treatments, about their care pathways. What do we do in that situation where the doctor is not the super knowledge expert who knows everything and the patient is not the passive, relatively uneducated individual who doesn't know much and will obey what the doctor says? That model disappeared, I don't know what, 30 years ago? If we still practice it today, we're out of date. The days of treating the patient as in some way an intellectual inferior are gone. However, what I will emphasize is patients are not a singular set. There are people of varying levels of capability, willingness, interest, time, financial resource to invest in their learning of their own care. So we shouldn't assume that everybody knows nothing. We shouldn't assume everybody knows everything. We need to be sensitive as health professionals to the individuality of the person, the level of knowledge they're able to obtain, the level of knowledge they want to obtain. But really the call to action to health professionals is to be a partner with your patients. That is something that I've been preaching for decades, but I do it a little bit less than I used to. But really, to what extent are people as professionals treating the patient as a collaborator in care decision making? And I remember the time when I had a particular patient who was, very well educated, who came in with, I think, 50 or more pages. And he said, well, doctor, I know you can't read it now. I'm going to give it to the receptionist. They'll put it in your tray for reading later. And I remember saying to him, I can't do that. I don't have that time. I'm going to, if you're capable of doing this level of research, I need you to also summarize. And you're welcome to be my research assistant. I'm happy to learn about what you learn and to add it into what I know about the disease so we work together on it. But you've got to help me. I can't absorb the level, I can't invest the time in your health that you can invest in your own health. I can't equal you, but you can help me. And I think that's one way. Another way is to invite patients into joint decision making. There are pros and cons of two treatment choices. Let me explain to you those two choices a little bit. Doesn't have to take very long in a busy room. And let the patient be part of decision making. Or maybe they're not quite sure, that it's a bit hard. You say, well, look, here are a couple of websites. Go away, take a look. See me in a few days when you've had a chance to weigh up these things. And then we can have an informed discussion. A motivated, committed patient who feels empowered in the process will adhere to their treatment better, will be more confident following your instructions. You'll almost certainly get better health outcomes than if you treat the patient in a patronizing way. So it's a worthwhile investment. And I would say that an increasing number of patients want that kind of relationship because we are, everybody's exposed to more health information. They're more knowledgeable than they were a generation ago. And the tools are getting better, as you pointed out. So I think we have to look at healthcare delivery in that balanced partnership model. I know many, many clinicians who've done that for many years. So I don't know enough clinicians to tell you how many in Europe feel that way. But I think we are, and what I'm describing is not new. It's already widely practiced by many, many dear colleagues I know. But I think we need to penetrate everybody.
Yeah, absolutely. It's interesting how you touched upon the topic of trust between different partners and the dynamic that happens between different stakeholders in healthcare. In your career, you've been working a lot on building trust and consensus across diverse healthcare data stakeholders. Where do you see that frictions usually occur? And where do you see we currently are in this whole era of not just fake news, but also fake images, fake information that we have because of AI? So, how do we still keep building trust and consensus in healthcare data to advance better healthcare outcomes?
Right. So let me start with the trust between actors. So the European health data space places an obligation on data holders, people who might have personal data or anonymized data sets on the health of individuals, to make that data available to others who might need to use it through the health data access body data permit decision-making process. Now, that's an obligation to share data. And it is one of the possible models that one can adopt to make data more widely used across stakeholders. But the other model is actually an incentive model where you say, rather than forcing you to make your data available, we'll make it worthwhile to share your data. And here I'd like to very quickly say that I'm not a real believer in financial incentives. I think they're usually counterproductive. Recovering costs is
Why?
fine. Well, because
Why are
it
they
encourages
counterproductive? Yeah.
it's so if you separate helping paying a fee to access data that helps the data holder or the data intermediaries to process the data, maybe helping to pay, making a contribution towards the cost of a higher performance server that will host the data, or paying towards the salary of somebody who extracts data sets and cleans them, makes them available. You're paying for the machinery that makes the data available to you. I think that's perfectly reasonable. I mean, expecting, for example, a hospital that has hardly enough money to care for patients to also employ staff and have tech that deals with giving the data to everybody else for free, it's not reasonable. I think hospitals can't be expected to fund that out of their healthcare operating budget. So it's reasonable. But the moment we start to say data, the data itself is sold, is profit taken, we enter a scramblingly dangerous marketplace for data where the highest bidder wins, and where we will not see equitable access to data. We will see unequal access to the data. The wealthy organizations will buy the rights to data. They'll buy exclusive rights to data if they can. And we will create a market where profit is taken and so on. And when I've worked with patient groups over the years about, should pharmaceutical industry, for example, pay for data, they give a pair of answers that is interesting. They say it's not reasonable that pharmaceutical industry should be able to use our data and make their drugs more cheaply, more effectively, for free. They don't like that idea. But they also say, no, we don't want the NHS or any other health system to sell my data. We don't find that an acceptable model, selling data. So when I've only worked with small numbers of patients, but in various focus groups and workshops and meetings, like the meeting you mentioned at the start, where we met at the European Patients Forum Annual Congress. But I've done it over about 20, 25 years. So I've done it over a long period of time. And it has built up in me a feeling of consistency. And what I described, that the pharmaceutical industry or the tech industry or others should contribute financially to the data provisioning ecosystem, but not buy data. And healthcare organizations and data brokers and infrastructure people should receive money as fees from data users towards their operating costs is reasonable, but a marketplace model, not so. I think it brings out the very worst of humankind behavior, and I'm not keen on that at all. Now, I realize that's a
Absolutely.
personal view, but it's a personal
No, but
view
it's
that's informed by a long time in the field and by many, many conversations and panels where this question has been raised. It was actually
yeah.
only about 9 months ago, I was moderating a panel where this question was actually raised, and the consensus across all panel members was against incentive financial payments that are to do with persuading people or buying data. They were very much against it.
Question: was the
Hmm.
panel so were the participants of the panel European? Was it beyond Europe? Because I think
Yeah, it's a good question. I can't
it's
remember
a
everyone.
European view where we basically
It was a multi stakeholder panel. We had industry, we had public, we had patients. But I think, and I'm sorry, I can't remember everything. I don't remember anybody not being from Europe.
yeah.
The event contained people from other countries, and we had speakers from transnational bodies like the OECD. But I don't
Mm,
remember whether my actual panel was non-Europe. However, a couple of the organizations, although the people came from the European office, they were global organizations,
yeah.
including one global pharma. So, so I think
My
they were
only
looking beyond
my
Europe.
only point is that basically the way that you described how healthcare of the future should be designed is very much aligned with the ideals of access to care and solidarity that are highly European
Yeah, yeah,
values. And it's also
yep,
something that Americans sometimes miss when it comes to, the way that the
yeah.
American healthcare system is designed. But to
I
avoid
think
like,
what I'll just quickly say to you that I think it's
yeah,
helpful you've raised this point, and I think it's good for transparency to the audience to know that although I do some international work developing ISO standards and so on, a lot of my history is European, and I think it's very true to say that my interactions, my learning has been mostly within Europe, and so the answers to all the questions we've discussed so far really do reflect European values. You're absolutely right. I'm not honestly global. That would be
yeah.
cheating if I pretended that. Thank you for raising that. That's completely true.
Yeah. It wasn't really meant as a critique or anything. It's just
But it's a
um,
context. It's a valid
yeah.
context to highlight.
Exactly. Yeah,
Yeah,
exactly. We're running out of time, so I just want to
sure.
close up with your expectations or your hopes for the next year or two. Where do you think that the discussion is going to go? How do you see that potentially, I don't know, EHDS is going to be developing, or what are the topics that we should be discussing potentially when it
Right.
comes to healthcare data?
Yeah. So I think even though the EHDS is seen as an enabler of a data ecosystem, I think even more importantly than being an enabler, it's been a wake up call. It's got everybody talking. It's got everybody realizing that we are not as ready as we should be to able to get the best value from data. And to me, that's already happened. It doesn't need to succeed or fail. It's already succeeded in getting stakeholders talking, getting us together. We had a massive attendance at our conference 2 weeks ago, but more importantly, each of the breakout groups had stimulating discussions. And I think getting stakeholders talking, how can we act together? How can we work together? For me, the next 2 years will be about accelerated bottom up action. So not waiting until the top down implementing acts are ready and saying, until they're ready, we don't know what to do. There's enough we can do to get on with it. And I'm sensing now a really exciting energy in Europe to say, so let's get ourselves ready. Let's start making use of data. We don't need to wait until the first health data access body permit allows us to share a data. We can start sharing it now. Anybody
Mm,
want it can approach us
let's
straight away. Let's
to
get
summer
going.
Exactly. To summarize, let's not ask ourselves if we can do something, but how can we do it? So
Yeah,
Deepak,
yeah.
thank you so much for the discussion today. We should definitely have another one because there's tons of other
Yeah,
things that we could talk
I'm
about, I'm
sure.
sure.
But they've been fascinating questions, and I've really enjoyed speaking with you. Thank you very much for inviting me.
Well, thank you again, and I'll definitely be in touch. I'm serious about a follow-up in 2026.
Okay. All right. Look forward
Awesome.
to that.
Thank you.
Cheers
Take
then.
care. Thank you.
Bye.
Bye.
Bye.